This is part 4 of the lecture on imaging of the salivary glands. Sometimes we encounter cysts arising within the salivary glands. The most famous of these is the ranula, which is an obstruction of the sublingual gland in which the gland itself begins to expand and accumulate saliva. If the ranula is confined to the floor of mouth where the sublingual gland lives, then it's called a simple ranula. But if it becomes large enough that it burrows through or around the back of the mylohyoid muscle, then it's called a plunging ranula, and it presents as a neck mass instead of a floor of mouth mass. Other salivary cysts include lymphoepithelial cysts, which are unique to the parotid gland because only the parotid glands have lymphatic tissue, branchial cleft cysts, simple parotid cysts, and then there are some things that are not actually salivary cysts but can mimic salivary cysts, including lymphadenitis, particularly from tuberculosis. Warthin's tumors, as we discussed earlier, can be non-enhancing. And sometimes ductal dilatation. If a duct is obstructed, it can expand, become spherical, and look like a cyst. Let's start with ranulas. Here is an example of a ranula. The bulk of this cystic mass is actually in the submandibular triangle. Here it is right next to the submandibular gland. But if you look carefully, you can see that there is a tongue of the cyst that extends around the back of the mylohyoid muscle and into the floor of the mouth along the characteristic location of the sublingual gland. And this replacement of the sublingual gland with a cyst that extends down into the neck is what allows us to make a diagnosis of ranula. This one, because it has a component down into the neck, is a plunging or diving ranula. Here are multiple cysts involving both of the parotid glands. This is the characteristic appearance of lymphoepithelial cysts. These are associated strongly with HIV infection. Interestingly, the presence of lymphoepithelial cysts can even predate seroconversion to HIV positivity. So this can be the first sign of the disease. In fact, these lesions are sometimes solid, which is why some people prefer the acronym BLEL for benign lymphoepithelial lesion, but they're usually cystic, and the term lymphoepithelial cyst has persisted. The bilaterality is an important clue, and of course, the HIV status, another important clue. Here is an example of a branchial cleft anomaly. This lesion is in a characteristic location just adjacent to the external auditory canal. It is in fact a duplication of that external auditory canal, and this is a type 1 first branchial cleft cyst. We cover these lesions in greater detail in the lecture on cystic neck masses. This is an example of a simple parotid cyst. There's nothing about this lesion that would allow you to radiologically make that diagnosis, but it belongs in the differential for cystic masses in the parotid gland. A perfectly spherical mass is more likely to be a simple cyst. Here's an example of a lesion that looks a lot like a type 1 first branchial cleft cyst. It has sort of a parallel look to the external auditory canal, although it's a little far away from the external auditory canal. It's taking the same basic course, and in fact that's what I thought it was when I first saw it, because this is a child, but it turns out this is a child with an infection. This is atypical mycobacterial infection of a lymph node, a pre-auricular lymph node. And this cystic degeneration is characteristic of that disease. So is skin thickening, and so perhaps there is a clue here that we're dealing with mycobacterial infection rather than an infected branchial cleft anomaly. Here's an example of how ductal dilatation can mimic a cystic mass. This is actually a patient with Sjogren's syndrome, which we will talk about in more detail. And this looks like a cystic mass, but in fact it's just a dilated duct, which explains that tubular configuration. All right, moving away from masses, let's talk now about infections and inflammation in the salivary glands. The salivary glands can be affected by viral or bacterial infections. The most common viral infection is mumps, and we see that very rarely, and it usually does not require imaging in any case. Bacterial infection, much more common. One of the most likely causes, although not a requirement, is calculi, stones obstructing the ducts. The 2 points that are most likely for stones to lodge are at the hilum of the gland and at the puncta, where the duct feeds into the oral cavity. Autoimmune causes are also common. The best known is Sjogren's syndrome, but there are other variants like Miculate syndrome and Sicca syndrome, and we will talk about those in more detail. Radiation changes are a form of inflammation within the gland, and we'll talk about that. Kuttner tumor is a very confusing diagnosis. It is actually a chronic sialadenitis, but it presents as a mass and looks just like a tumor on imaging. So it belongs on the differential of tumors, perhaps, particularly in the submandibular gland. And then we'll also talk about Kussmaul's disease, which is a fibrous plug in the duct. This is a very rare disease and really doesn't merit much discussion, though. Stone causing an infection. You can see this large calculus, probably 1.5 centimeters, obstructing Stenson's duct, and the duct itself has become enlarged and has abscessed. You can see the enhancing wall, and all of the ducts inside have become infected and obstructed. A classic appearance for sialolithiasis causing sialadenitis. It's not usually this extreme. Another important finding is the infiltration of the surrounding fat, which confirms that we're dealing with an infection and not a tumor. Sialolithiasis most commonly affects the submandibular gland, then the parotid gland, and least commonly the sublingual glands. It's not entirely clear why they would be in this odd order. Evidently there is some mechanical issue with Wharton's duct that makes the accumulation of stones more common. 25% of the time you will find more than one stone, so by all means, once you see one, look for the others. Sialolithiasis is the most common cause of chronic sialadenitis, so in patients who are inflamed, look for the stones. Clinically, these most frequently cause intermittent obstruction. For example, patients will complain of swelling in the affected gland only when they are eating. The stones tend to lodge at the bottlenecks in the ductal system, that is, the hilum of the gland and the puncta of the duct. There are multiple ways to look for sialoliths. Unenhanced CT is by far the most common way to do so, although traditionally sialography has also played a role in this evaluation. Less so nowadays. Here's an example of 2 calculi lodged at the classic location. Here is a calculus at the hilum of the submandibular gland, and here is a calculus at the puncta of Wharton's duct, right where it empties out lateral to the frenulum that anchors the tongue. It's important to know where these ducts empty out so that you know where you're looking for these stones. This is the classic location for the Wharton duct, but in the parotid gland, Stenson's duct empties out alongside the second mandibular molar. Here's an example of parotid sialoliths within the gland itself. These are not causing obstruction, but they are at risk of doing so. Sometimes you will get a series of stones along a duct. Here are fragments of a broken stone that have lined up along Wharton's duct. Autoimmune diseases. Sjogren's syndrome is the most common autoimmune disease to affect the salivary glands. Sjogren's disease is sialadenitis in the setting of connective tissue disease. Sjogren's disease does not exclusively affect the salivary glands, it affects a variety of different glands, but the salivary glands for some reason get top billing. The conjunctiva, the lacrimal glands, the bronchi, the skin, the esophagus, the genitals, all involved with Sjogren's syndrome, but the salivary glands are what it's known for. Now, if you have a patient who has exclusive involvement of the salivary glands, we call that Mikulicz syndrome or primary Sjogren's. There are childhood and adult forms of Sjogren's disease, and they have somewhat different pathophysiologies. The classic appearance of Sjogren's syndrome on silography is a mulberry tree or the string of pearls. One important thing to understand about Sjogren's syndrome is that these patients have a heightened risk of lymphoma of the salivary glands. How heightened? 14 times as great as the general population. Thus, if you have a patient with Sjogren's syndrome who has new swelling in their gland, you must consider lymphoma as the top of your differential diagnosis. Don't assume that it's just an acute inflammatory episode. Here's an example of the classic string of pearls sign on a sialogram. You can see areas of ductal dilatation interspersed with areas of stricture, and you can see involvement of the distal ducts all through the gland with areas of enlargement even in the smaller ducts. On cross-sectional imaging, this is the classic appearance where the glands are enlarged and the enlarged ducts appear as bright T2 dots scattered throughout the gland. This is a classic appearance, an Aunt Minnie, if you will, for Sjogren's disease of the parotid glands. Although most commonly symmetric, occasionally Sjogren's disease will affect one gland more than another. Here's an acute exacerbation where there is edema and inflammation throughout the right parotid gland, but the left parotid gland appears to be unaffected, at least in this episode. The use of therapeutic radiation has a particular effect on the salivary glands. These are not the only signs of prior radiation, however, so it's worth going over all of the signs of prior radiation. The submandibular glands become more dense on CT and more enhancing after the administration of contrast. This finding, along with the other three findings of prior radiation, including stranding of the fat planes, edema within the laryngeal mucosa, and a thickened platysma muscle, are all expected findings after therapeutic radiation and should not be mistaken for alternate pathology. Here's a patient with the classic findings. Notice that the submandibular glands are much brighter than they should be. That's not infection, that's the radiation. Notice that the platysma muscle is thickened. Notice that there is stranding of the subcutaneous and deep fat, and also that there is thickening of the mucosal walls of the oropharynx and larynx. Here's an example of a tumor that's not a tumor. This submandibular gland has an area in the center which is non-enhancing and would easily be mistaken for a malignancy. However, this turns out to be a chronic inflammatory disease. This is a Kuttner tumor of the submandibular gland. These are rare, but an important thing to remember on the differential diagnosis of submandibular masses.